to acknowledge this land on which the Fields Institute operates. For thousands of years, it's been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. Today, this meeting place is still the home to many Indigenous people from across Turtle Island, and we're grateful to have the opportunity to work on this land. And I'll turn it over to Zhen Hong to introduce our speaker today.
Thank you, Ben. Thank you very much for everyone for coming in. I understand from the list that Jane does bring some unusual tendencies to the Fields Institute, the M4PH colloquium on mathematical public health, and it is a fantastic opportunity to really catalyzing interdisciplinary interactions and collaboration. I'm very pleased to have today's speaker, a very own of our own member of our own network and a dear colleague at York University, Jane Heffernan. And I don't think Jane really need introduction to this audience, and she has a very impressive list of title and leadership roles, including membership from the College of New Scholars of the Royal Society of Canada. She was elected to the president of the International Society of Mathematical Biology, and she's co-leading a number of projects. In particular, the project I believe is co-led with David Bukovich for Serum Network, and she is a York Research Chair in Modern Infection Immunity, and is involved in a number of initiatives York and nationally. So with that, Jane, I will give it to you now.
Thank you. Thank you so much for inviting me, or twisting my arm to finally give a talk at this colloquium. So happy to be here. So today I'm going to be talking about modeling immunity for COVID-19. Apologies, probably if a few of you have seen slides from this talk already, but I'll be also giving some updated information on some of our studies that we've been doing in my lab at York. Okay, before I get started, I just want to acknowledge that this work is in collaboration with lots of different people, from modeling, from statistics, from public health, and has a lot of funding to support all of the work and all of the postdocs and grad students in the group as well. Okay, so I'm interested in modeling immunity generally. So when we think about this, I'm really interested in trying to understand how immunity develops in an individual, but also try to understand the protective effects that individuals gain from having immunity. And so there are two different levels of immunity that we're really interested in. One is so the first, and this is for all immunology studies, we're interested in understanding how individuals can be protected from infection. And the second level is that if an individual does get infected, what's their protection against having severe symptoms or severity of disease? And so we're really looking at susceptibility in two different levels. So we have susceptibility to infection, and then if infected, what their severity of infection will be. So when we're trying to understand this, we're really trying to understand initial conditions of the immune response. So we're looking at stochastic models to try to understand what the probability of infection is, given that we have protection in the individual. And then if we do get a ramp up in infection, then trying to use area under curves to determine what the severity of the symptoms will be when we're looking at viral load or infected cells in the body. But when we do this, we also are trying to model what the gain in immunity is post-infection. And in parallel, we also try to model what the gain in immunity is post-vaccination. So what we do is we give an individual an infectious disease, and we model their antibodies and their T cells to try to understand what level of immunity they gain. from a mild, moderate, or severe infection. And then we try to understand how that immunity can change over time, whether it wanes or whether the efficacy of that immunity will just effectively wane because the pathogen is evolving away from their immune response. So we look at all of these things. So we have our susceptibility, our initial conditions, and we look at our end conditions of our immunity as well. So this is all important because our populations are made up of lots of individuals. And what we really want to know is what does our distribution of immunity look like in the population? So, and that immunity is from infection and from vaccination. We have lots of different backgrounds in all of our different cities. So we want to understand what our immunity is gained from, say, the vaccination program, the childhood vaccination program, versus all the different infection histories that all of these individuals have, and whether they have comorbidities that are going to affect all these things as well. So given information that we gain or the results that we have from our in-host modeling studies, we then use this information to parameterize the immunity distributions that we get in our population. And then we use epidemiological models that incorporate age and or immunity in the population so that we can track how the immune system moves, how the immunity distribution changes over time. Okay. So that's just to say that, so what we have is, so in our in-host modeling, we have individuals that get infected, and then they have some infection, they clear it, and then maybe they have an exposure again. Then a little while later, they get an inapparent reinfection maybe, and even down to like many, many years from their initial infection, they might get a mild or inapparent reinfection. And we're interested in knowing what the probabilities of these inapparent or mild infections are versus severity of infection as the time extends between the original infection and the current time. And so you can really think about immunity as being on like this conveyor belt as well, where you have individuals that get infected. And so they're initially naive, they get some immunity, and then maybe over time, their immunity might wane effectively because maybe the pathogen is evolving, or maybe their immune system cells are decaying and their antibodies. And so you might get, some decay, and then maybe they'll get reinfected. At the same time, you can also think that individuals were getting our childhood vaccine. So we get our vaccine, and then we get a booster dose a couple years later. So where on this conveyor belt are we going to lie with all of our history? And so with COVID-19, we're interested in looking at this from the very beginning of COVID-19 to current day, and trying to understand where everyone within a particular age group and comorbidity status, what their immunity is going to look like. Okay, so we were posed with a particular question pretty early on in the pandemic, is to try to understand what the seroprevalence of our population would be. Seroprevalence is a particular measure of immunity in a population that's measuring antibodies. And so I also worked with the COVID immunity task force in an immune monitoring group to try to understand, given seroprevalence data, our antibody data from, say, important data sources like Canada Blood Services, where they do measure the antibodies in some blood donors to understand what the antibody levels look like, where we're looking at spike protein and also the nucleocapsid. And so spike protein early on, both of these measures would be the same because early on we only had infections. And then later on, when we bring in vaccination, there's a split because our vaccines include the spike protein. So now any measures of anti-spike anti-S are going to give us measures of immunity and from vaccination and infection, and anti-N, which is the nucleocapsid, are going to give us measures of immunity from infections only. And so we're interested in trying to determine what the seroprevalence of these antibodies is going to be in the population. We can use data and we can use statistical models, which is what we've been using in the COVID immunity task force. But at the same time, we can be using dynamical systems where we have distributions of populations with the different immunity levels in the population that we track over time. And so that's what I'm going to talk about today. So things that we need to know, though, in order to be able to do this type of quantification are, can we quantify the level of immunity against SARS-CoV-2 over time from vaccination and infection by age and considering different variants of concern? And when we talk about vaccination, we also need to consider the different types of vaccines. And so in order for us to do this quantification, we need to understand immunity generation from vaccination, understand immunity generation from infection, and understand immunity protection by age and variant of concern. And so what we want to do is track the infections and vaccinations by age. We need to consider the vaccines that we've been using, and we're going to look at the Canadian population, so mRNA, so Pfizer and Moderna, and the adenovirus, the AstraZeneca vaccine. But we also have to track public health interventions and behavior. And so we want to understand how contact structure changes over time as well. At the same time, we're interested in knowing how your effective susceptibility and effective transmissibility are affected by your behavior too. So are you continuing to wear a mask? That is going to affect your susceptibility. If you're infected and you're wearing a mask, that's also going to affect your effective transmissibility. Okay. So what is immunity? Typically, when we're talking about immunity, you usually consider a protection against infection to be conferred by antibodies and B cells. And your protection against severe infection, if you get infected, is usually conferred by your T cells. Now, there's a big distribution here, and it's been shown for COVID that high T cell memory can also protect you from infection. But I'm not really going to go down into the nitty-gritties, but essentially, basically, that's what people really talk about, that antibodies are your first wall. But if the infection gets past the antibodies, then you've got your T cells and they affect your severity of infection. So we're looking at protection against infection, protection against severe disease. We're going to look at waning immunity. COVID-19 or SARS-CoV-2 is a coronavirus. We do know that coronaviruses do have waning immunity in individuals. And we also are going to consider different variants of concern, like immune escape mechanisms, because different variants of concern can evade the immune system such that individuals who are, say, protected against Alpha and Delta might not be protected against Omicron. So we have that type of thing that we need to consider as well. Okay. Interestingly, when we're talking about behavior, you can think about behavior as being that can be modeled in a very similar way to how we model immunity. So people can uptake behaviors such that they're protecting themselves from infection. And then naturally, those behaviors can wane over time as well. And so in our group, we also do a lot of work on behavior modeling, but I'm not going to talk about any of that today, but just understand that a lot of what we do with behavior modeling is included in the assumptions that we're making in our epidemiological models. Okay. So first, I'm going to talk about some work that we have done in our in-host modeling. On the left-hand side here, I have a diagram of an in-host model that we developed for vaccination. And we look at both using this model and slight variants of this model. We look at vaccines like AstraZeneca, Pfizer, and Moderna. And so what we're interested in here is, so here we have our vaccine vectors. So here's our adenovirus vaccine, and here's our mRNA vaccine. These components in the vaccines get injected into your cells or into your tissues, and then it activates the immune response in slightly different ways. But when we get our data from clinical trials or from labs that we're collaborating with, we get measures that are similar. So you can think that we'll get measures of antibodies, we'll get measures of some interferon gamma probably, and we'll get some interleukins, and IL-6 is a popular one that we'll get. We might not get measures of the T cells. Usually we don't. We usually don't get measures of B cells or plasma cells. We usually get antibodies, some interleukins, interferon gamma, and another measurement called granzyme B. Okay, so what we've done is we've developed an in-host model of vaccination. We then scale it down to a few different differential equations so that when we get our data, we have statistical power that we can then use our model to fit to the data to determine model parameters for the immune response. So we've done this type of modeling for AstraZeneca and Pfizer and Moderna using individual patient data as well as cohort clinical trial data. Okay. On the right-hand side, we have a similar type of flow diagram, but here we have an infection. And so what we have here is we have our infectious virus. Our infectious virus can infect target cells. The target cells then go through an eclipse phase. This eclipse phase could be 1 stage, 2 stages, 3 stages long. I'll talk a little bit about that later. And then once it's gone through the eclipse phase, the cell then becomes a productively infected cell and starts making new virus particles. When this is happening, so this is the basic model of virus dynamics in the body, but it ignores the immune response. So you can add on the immune response into this where you have T cells and B cells, whatever cells you want to model that are part of the immune response, they can get activated or primed from the infected cells or the virus. And then these T cells then are related to an interleukin, an interferon gamma, and a granzyme B. And we could also get antibody data where we'd have to add in some B cell components here. Okay, and so this is essentially down here, the bottom right-hand side is a diagram of how SARS-CoV-2 infects the tissues and cells and your body. And we mathematically model that up here. Okay, but in both cases, for vaccination and infection, we have to consider what data we're going to get. And then we have to understand how we can incorporate that data into our models and try to understand how our model components or populations are related to activating or secreting different components of the immune response, as well as these components can then also have another stimulation, or it can also try to dampen stimulation of the immune response as well. Okay, so using these models for vaccination and infection, we have fit our mathematical models to different data sets to understand the accumulation of immunity, but also to understand the severity of infection that individuals can get. Okay, so on the left-hand side, here is some results that we got from our studies for AstraZeneca and Pfizer and Moderna. And just in summary, I'll highlight a couple of results. So in the AstraZeneca study, we were able to show that after 2 doses of vaccine, we get a particular decay rate from our immunity. We are also able to show that different age groups could have slightly different outcomes. And for fun, we are also able to show that if you make the second dose a smaller dose size, you can still get effective immunity outcomes in that type of vaccination scenario, say where vaccine is limited. Okay. In the Pfizer and Moderna study, where we fit a mathematical model to cohort data, we were able to show that Pfizer has a higher decay rate in antibodies than Moderna afterwards. So your immune response won't last as long. But we're able to show that they're certainly comparable. It's important to know that. So here on the y-axis, we have an IgG antibody response, and these are in arbitrary units. So this does not say that the green is higher than the orange. You can't say that there's a comparison directly because these are in arbitrary units. Here you can see that there's one study that had Pfizer and Moderna in the same study, and you can see that the Pfizer data lie on top of each other in that one study. So this just shows that you can't look at Moderna as being better than Pfizer here. Okay, but anyway, so we fit the mathematical model to the Pfizer clinical trial data from different groups. And what we were able to see is that Pfizer has a quicker decay rate of the antibodies post-vaccine than Moderna. That also, depending on your age, you'll have a quicker decay rate if you're in an older age group versus if you're in a younger age group. So here we've quantified antibody output. I'm not showing anything about T cells, but we also have quantified T cell memory generation from these mathematical models to move forward to look at different levels of susceptibility and severity of infection later on. So on the right-hand side, we have some work that we've done on looking at infections. So where we fit that in-host model to different data from different immunology studies or cohort data from the literature. And so what we found here, so here in this figure, we can see that we've taken data from different studies from the literature that represent infections from different time periods of the epidemic. And we fit the same mathematical model to these different groups. And you'll see that in quite a bit of these,
that is
sorry. Okay, that for two of these different groups, we're really not capturing the ramp up infection. We're really only capturing the decay in the viral load. But this data set, we do capture the ramp up and decay, and somewhat we do also in this study here, where we're also looking at nasal data and saliva data. So we take this information, we take the same model, and we fit it to patient data from some other immunological studies. So here we have interferon gamma measures, interleukin-2, and granzyme B from individuals that have had severe, moderate, and mild infections. And here you can see that a mild infection has a lower level of interferon gamma and interleukin-2, but a very similar level of granzyme B early on. Moderate infections are a little bit higher, and then severe infections. With granzyme B, you can see you get this different type of decay rate from mild, moderate, and severe infections later on in the infection or post-infection. Down here as well, you can see how we've plotted what our mathematical model fitting looks like for a moderate infection, a mild one, and a severe infection. You can see a pretty good correspondence to the data. So from all of our in-host modeling studies, we have been able to find some particular results, which I will summarize in a couple of slides. One of our more mathy studies that we did is we took our in-host modeling study, so the one, this model here, so is this model here, and we did a dimension reduction analysis on the model. To really try to understand what components of the immune response are dominating the immune response over different timescales. And so we were able to see here that, you can observe here that antibody priming is important early on. Later on in the immune response, we really want to be looking at autocatalytic production and antibody decay, which just makes sense. But on these different timescales, we're able to simplify our model down to a much simpler system or a smaller number of equations. And this type of analysis can help us working with immunologists and other labs who are interested in following infectious diseases, that when you design a study to take different samples at particular time points, depending on what you want to measure, you're going to want to measure early on or later, or if you want to measure a suite of different things, you need to pick your time points at which you take your samples in an informed way so that you can make sure that you get at least 2 or 3 data points for later on, or 2 or 3 data points early on, depending on what you want to measure. And this just shows what the simple models look like compared to the data where we simplify our 6 or 7 equation system down to 2 equations in some of these spots, and you can see a nice fit. Okay. We also have taken this model here where you have T, E, I, and V, so the TEIB model. And we extended our study so that we don't just look at one stage in the eclipse phase where the cell is infected but not productively infected yet, but instead we break it down into K equal stages. And when we fit our TEIB model now where we have K equal stages in the eclipse phase, we're then changing the shape at which the eclipse phase is in terms of the average lifespan distribution. And so by doing this and fitting this to data, we're able to show that as long as we have more than 2 stages in the eclipse phase, we're able to match the data fairly well. But the strongest support shows that we should really be choosing 3 stages to be in the eclipse phase. So that's interesting when we're looking at these infections. And so we can go back and we can redo a lot of what we've done before, where we take only K equal to 3 and redo some of our parameter estimates from the previous studies on the previous slide. Also interesting is that if we take different parameters in our mathematical models, like the clearance rate, the death rate of infected cells, the budding rate of the productively infected cells, and so on, we're able to see that different parameters are going to have different effects on the outcomes of the system. And we can see here that if we want to measure the peak, if we really want to align the peak of our model to the data, we need to vary these 2 parameters. But if we're really interested in aligning different decay rates for the different age groups, for example, then we're interested in looking at D. Whereas the budding rate and the clearance rate of the virus don't actually have a huge difference in a lot of the peak or the decay rate, maybe just slightly different in the peak here. Okay, so those are more mathy studies that we've been doing in the lab. Okay, but now to summarize all of the in-house modeling that we have done over COVID for model fitting, we found that immunity gained after infection correlates with the severity of infection. So mild infections gain some level of antibody and T cells, but if you have a moderate infection, you get a higher level, and a severe infection, you get even more. That immunity gained from infection and vaccination can wane over similar periods of time. That's important. So that gives us an idea of when should our booster doses for Pfizer, Moderna, AstraZeneca occur post a previous dose or post an infection. So we take that information into account. So down here, we've also found that mild infections are shorter in duration than moderate, and moderate infections are shorter in duration than severe infections. We also find that the viral load correlates with severity of infection, and so it will affect transmissibility. And so that means that severe infections have a higher level of transmissibility than moderate infections, and moderate than mild. and that the viral load then can be expelled a lot. Higher levels of viral load can be expelled from severe infections versus mild and moderate. Okay. Also, though, there are quite a few things that we don't know from the in-host modeling studies that we've conducted, and so we also then have to scour the literature to inform some of our assumptions that we can make when we're thinking about the spread of COVID-19 in the population. And we also, of course, always do a sensitivity analysis to see how some of our results are affected by these different assumptions that we're making. So these different outcomes are really important now when we want to start thinking about the epidemiology of COVID-19. We're interested in tracking infections and vaccinations in the population, but when we're looking at our tracking infections, we only know about a subset of infections, those ones that are reported, or after Omicron, we only really know about the hospitalizations. We don't really have an idea of good reporting of infections after Omicron has come through the population. And so taking in some of this information, we're able to now parameterize an epidemiological model so that mild infections are shorter in duration than moderate and severe. That mild infections have a lower transmissibility than moderate, and moderate have a lower transmissibility than severe. But then going back to what I was talking about with our behavior modeling, we then need to take it we need to consider that severe infections know they're infected because they have symptoms and they've gone to the doctor or go to hospital. And so they'll be taking precautions to remove themselves from other people and wearing a mask and so on. So it reduces their transmissibility effectively. So now we're going to take all this information from our in-host modeling and embed it into a population level model of COVID-19 infection and vaccination, where now we're going to stratify the population by 5-year age groups. We're also going to stratify the population by mild, moderate, and severe infections. And we're going to stratify by their immune system status. Okay, so this is the mathematical model for one 5-year age group here. And so what we have is we have individuals that are totally susceptible. They can have, when they're infected, a mild infection, a moderate infection, or a severe infection. And depending on what type of infection they have, they then gain a level of immunity where they move into the S2, the S3, or the S4 classes. If you have a severe infection, you move into S4, and this we assume that then you get neutralizing immunity such that you cannot be infected for a while. But this level of immunity can decay down to S3, which is the level of immunity that you get after a moderate infection. And here there's some susceptibility to infection, but then there's a high degree of protection against severe infection. The immunity then can also decay down to S2, which is the same level that you get after mild infection. And so here you have some protection against infection, and you have a moderate level of protection against severe infection, as well as moderate infection. So you can think that we move people more down towards the mild infections if they have some immunity in their bodies. So this is a dynamic process where you gain immunity through infection, and your immunity can then also decay over time, just naturally through decay of antibodies and death of T cells. Okay. When vaccination came in, we had to include 2 doses of vaccine into the system. And so here we're color coding our vaccine doses with similar shades of purple as our susceptible classes up top, or our immune system classes. And so that means that we're going to assume that these similarly shaded shades of purple are going to have the same characteristics in terms of their protection against infection and protection against severe disease. Just because we don't know exactly how to align them. So this is a simplifying assumption that we're going to incorporate in the model, and it's actually not a bad one. Okay, so the first row of vaccine that we get is here. And these two classes here are highlighted as non-neutralizing. That means that these classes can become infected with COVID-19, but then if those classes do, they're going to have a more mild infection. So we move them to mild. These darker purple classes all have neutralizing immunity like S4. So they're protected from infection. And so you can either get that by having one dose coming from S3 and one dose coming from S4, or having any two doses coming from any class. Okay. Excuse me. The immunity from your vaccines can also wane. And so we move you down one shade of purple over a similar length of time to what the immunity wanes from infection. Okay. So two more things that are important. One is that we know the distribution of comorbidities over all the 5-year age groups that we're modeling. And we use those distributions to determine what the probabilities of mild, moderate, and severe infection are. This is from a really interesting paper written by Clark et al. So it's here. We also know from this paper by Mishra, Knight and Mishra, that the initial reproduction number in the Canadian context, or I think it's actually Toronto or Ontario, lies between a high value of 1 and a mid value of 3. So we're going to choose for our mathematical model the middle point of 2.6. So we choose a reproduction number 2.6 for the wild type strain for COVID-19, and we use that to calibrate our beta parameter, which is in our force of infection. Okay. We also assume that there are 3 stages in our exposed period. That's to give us a nice distribution of the length of time that you're going to have in the mild and moderate and severe infections. And we also then align these things to look at how many, when we're looking at our vaccines, how many individuals have had infection or vaccination. We don't align them. We look at the results to consider these things. So looking at these populations, we can see who has never had an infection or a vaccination, or don't show that they have any immunity. So that'd be like S1. When we look at infection only or 1 dose of vaccine, then we can consider this here, or our S2, S3, and S4 classes. And 2 doses of vaccine, we can look at the darker shades of purple down here. So we can, using statistical studies, this is from the ABC study that's also funded by the COVID Immunity Task Force, we can compare our results to these other studies to see if there's some agreement. Okay, but when we incorporate different age groups in the population and different public health mitigation periods, we have to consider how the public health mitigation periods and non-pharmaceutical interventions are going to affect the transmissibility. So while we've been doing all of our modeling, we've also been gathering news reports, government reports, etc., to help us determine how our contact mixing matrices between the age groups are going to change over time and within that age group as well. So we have contact mixing matrices for each age group for school, work, home, and other. And we modify these mixing matrices to align with what the current non-pharmaceutical intervention policies are over particular time periods. And so here you can see what the different provinces look like over different time periods for their school, work, and other. We don't modify the home matrix because people were in their houses even during the most strictest times of public health interventions. When we do that, we modify our contact mixing matrix so that here is our contact mixing matrix that we get from this paper by Prem et al. To look at our 5-year age groups with no mitigation. Then we add in, here we have a little bit of work from home. Here we have some work from home and some school closure. And here we have the strictest mitigation, which was the full lockdown. What's important to know is that for all of these different phases of non-pharmaceutical interventions, we always find that this age group, the 15 to 19-year-olds, will have the highest average contact rate. And so when the vaccination program was being rolled out, we found that first, vaccinating the elderly was priority number one and healthcare workers, but that a second priority should be to get the vaccines into this age group as early as we can, because they have the highest contact rates on average, which will then give secondary benefits to all the other age groups in protecting the population. Okay, when we fit this model to data, we need to consider either reported cases or hospitalizations. And when we fit it to reported cases, we assume that all severe infections will be reported, some fraction of I3 will be reported, and a smaller fraction of I2. And this is all based through contact tracing efforts, as well as just individuals testing themselves if they want to go visit their grandma and so on. We have extended the model to look at booster doses. So I'm not going to go into a lot of detail here, but now this bottom, so here's the original boat looking model, and now we incorporate booster doses. And then we also are tracking our infections from our vaccinated individuals separately from individuals who have never been vaccinated at the top. And that means then that we can compare our results from this larger model to more data from statistical studies, like the ABC study that's funded by the COVID Immunity Task Force. Okay. So when we calibrate our model to the data, we have this parameter called Kappa that we have incorporated into our force of infection. And this Kappa gives us that calibration parameter or metric over different time periods of the pandemic. But this parameter Kappa incorporates in it just natural changes in behavior in terms of compliance with social distancing and personal protective equipment wearing. It also is going to be affected by testing rates and contact tracing rates, changes in virus transmissibility, like all the different variants of concern, and the weather. So we have in future work, we're going to try to tease all of these different components out of our parameter Kappa that we use to calibrate the model, so that we can really understand what compliance and relaxation looks like for social distancing and PPE use. Okay. So this is what our fitting looks like of our mathematical model to the data. We're also able to calibrate it. So that's to reported data. So this is pre-Omicron. Post-Omicron, we've changed the model to only calibrate to hospitalization data. And so this is what it looks like. And it's not bad at all. So then this is what our Kappa parameter looks like through that calibration. And then we're able to look at what our different distributions of immunity look like, those different S classes for our different age groups. And so here in green, we have individuals that are totally protected from infection. So that's the S4 plus those 2 doses of vaccine and booster doses. Here we have our S3, which is S3 and 1 dose of vaccine. Here's S2, and this is S1. These are individuals that are totally susceptible. But using this type of model, and up here in the white, these are our different waves of COVID-19 infection. And there's a red line at the very top. This is actually a curve, and that's a curve of the hospitalizations. Okay. What you can see here is that hospitalizations are a very small fraction of the total number of infections, which is intuitive. You can also see that we start the population out totally susceptible. We have some low level of infection early on. Then we have this big increase is not from infection. This is from our vaccination uptake. And you can see that our youngest age group remains in this highly susceptible class for a long time until it starts to get vaccinated around this time period. There's a period here too where you see this decay. This is when Omicron sweeps through the population and it has immune escape mechanisms. So, and it took over, became the dominant strain over a month. And so over a month, we change our waning rates so that we're looking at effective immunity such that we move people down one immune system class over 1 month using a different waning rate to represent Omicron. Here, we're just looking at two different scenarios post this line here, where we've calibrated our model to the data before this dotted line. And then we're looking at a prediction. We're changing characteristics of what the strain will look like after a particular period to try to understand what another wave of infection would look like and how this affects hospitalizations. Okay, so going back to the original question, we were posed a question on trying to understand seroprevalence in the population. So our mathematical model doesn't necessarily give us seroprevalence. It gives us immunity distributions where that information incorporated in is protection against infection and protection against severe disease if infected. But what you can see here is that if you look at this big ramp up here, up to about 80%, here you can see a big ramp up. This is from vaccination in the population. So this is a measure of anti-S antibodies. You can see this big ramp up happens around the same time. And then this is ramping up to almost about 100% by the end of 2022. That's antibodies only. We get the ramp up, but then we get some decay. And here with Omicron, we sweep through the population and we move everybody down an immune system class. And so here we're modeling effective immunity rather than just antibodies. You can also see here that there's a large increase in anti-N antibodies during the Omicron era. And so we move people down, and then we have all these increases that you see in the blue, yellow, and green here are increases in anti-N antibodies through infections. You can see the Omicron waves here that we're getting. So we have similar dynamics, but we can't do a one-to-one comparison between this COVID immunity task force plot where we're using a statistical model to our dynamical system. But one thing that we can get from this dynamical system that we can't get from some other models is that we can now look at the severities of infection by age. And so over the entire course of the pandemic, we can now plot what our mild infections look like in blue, our moderate infections are in yellow, and our red infections are severe infections by different age groups, where the different shades of each color are 10-year age groups here. We can also look to see that if we're just looking at severe infections, what fraction of severe infections are in, say, age groups 50 plus, 60 plus, and so on, so that we can look at recommendations for booster dose vaccination programs at particular times of the year. And so this is just normalizing it to this is just these two plots, but normalized. So you can really get a look at what the different shading looks like for your age groups. Intuitively, you'll see that if we're looking at mild infections, our youngest age group has a lot more mild infection than moderate and severe infections, which just makes sense. Okay. And this is just something I just talked about, where here, this was in August 2021, we were looking at this model, and we could see here that there was a low level of immunity in these age groups at the time. And so we recommended that there be a targeted vaccination program to get more 12 to 23-year-olds to go get vaccinated. Here we could see that most of the infections would be mild and moderate. You can see the increases in blue and yellow. But we also saw that if we looked at the severe infections here on the right, 50% of severe infections in age groups 50 plus. And so we recommended a booster dose for age groups 50 plus starting in September 2021. This is just a similar thing to what I talked about before. A final thing that we're able to see is that we can see when we were looking at COVID testing, we were able to show that the ascertainment rate is going to change over time, and that the ascertainment rate actually worsens when we have vaccination coming into the population. But that's because of the positive benefits of vaccination, as vaccine moves people down more towards the mild infection outcome, which are harder to ascertain in the population. So this is the last slide. So here we have outcomes from our dynamical system model. Here is the outcomes of the statistical model from the COVID immunity task force, looking at anti-S and anti-N over time. Here is data from the ABC study from the COVID immunity task force as well. And I don't have time to go through it, but if you look at all of these different classes from the ABC study, and you look at what these curves look like from the statistical model from the COVID immunity task force and Canada Blood Services, we do see similar outcomes from our dynamical system model. Even when we do a sensitivity analysis on many of our assumptions in terms of the waning rate and how protected you are from infection and from severe disease, we have some robust results. And so we have some confidence that this model, this large dynamical system that we have is actually doing its job. And so we're now extending this model to go past Canada, and we're applying it to other countries in the world and some of the United States. So this work was done by a large team, and it was funded by a lot of different entities. And if we have time, I can take a couple of questions.
Thank you, Jane. Thank you for the fantastic showcase of the in-host immunity modeling in action in progress.